Welcome everybody to this webinar, Treatment for Recurrent Ovarian Cancer. We've got a couple of people still joining. So without further ado, I am going to introduce you to Dr. Rowan Miller, sorry Rowan, who is Consultant Medical Oncologist, UCLH and Barts in London. And more importantly than all of those wonderful things is that Rowan has been on our expert advisory panel for the longest time at Overcome. I can't actually even remember how long, at least 6 years. She has been an absolute stalwart and is a complete expert and knows an awful lot. So we are very much looking forward to hearing from her. Okay, Rowan, are you ready?
Yes, thank you.
Over
Thanks
to
for that
you.
introduction. Like Victoria says, there'll be plenty of time at the end for any questions, so do put them in as you go along, and at the end I'll be happy to take any questions. So I've been tasked with talking about the treatment for recurrent ovarian cancer, which is no small topic, but I will go through some of the main points over the next 30 minutes or so. I thought it would be useful to start with what we mean by recurrent ovarian cancer, because there's a lot of different terminology used, and what people's understanding and what different people use may vary. So I think when we're talking about recurrent ovarian cancer, it's usually one of two things. One, it's ovary cancer that has returned after a period of remission. So after initial chemotherapy and surgery, with no evidence of disease on the scan and a normal CA-125, perhaps at some point in the future the CA-125 rises or a scan shows some recurrence. That's what's defined as an ovarian cancer recurrence. Or alternatively, sometimes you talk about ovarian cancer recurrence in someone who's perhaps not had surgery. There's cancer that's responded to previous treatment, say chemotherapy, and has been stable for some time, but then starts to grow again. And that would be a further recurrence. Multiple recurrences can occur over time. So we may talk about first recurrence, second recurrence, etc. And I think it's worth saying that one of the questions I get asked most is how can you have recurrent ovarian cancer if your ovaries have been removed? But what we define cancer by is always where it started, not where it is now. So if you have a recurrent ovarian cancer and we were to take it out and look at it under the microscope, it would look exactly the same as the original ovarian tumor. So even in the absence of any residual ovaries, ovarian cancer recurs because one or two cells has evaded chemotherapy and has at some point started to grow in the future. Now, the treatment for ovarian cancer is varied, and there are many different paths that we can go down, but I've listed some of the more common ones here: surgery, chemotherapy, expectant management or watch and wait, which I'll discuss, clinical trials, hormone therapy, and then I've included radiotherapy in brackets because it's not a standard treatment for ovarian cancer, but there are certain indications for recurrences that we may consider radiotherapy or stereotactics, so sort of more targeted radiotherapy. This is the European Cancer Guidelines for ovarian cancer. I don't expect you to be able to, to look at this in great detail, but I just show it to show that it's quite complicated and there are many different paths that we can take. But to basically summarize, when we're thinking about treating recurrent ovarian cancer, what we think about are some of the main factors that we consider is the timing. So when has the cancer come back relative to previous treatment? Where is the recurrence? What organs, if any, is it affecting? Is it causing any symptoms? What the response was to prior treatment, so whether that was the ability to do an operation before or the response to previous chemotherapy. But most importantly, what is important to each individual patient. So do they have any symptoms? What's their wishes? How do they tolerate previous treatment, etc.? Perhaps the kind of most binary or the most black and white is timing. And we define the time of recurrence from the date of the last day of the last cycle of chemotherapy. And we really use that to define whether a recurrence is considered platinum sensitive or platinum resistant. And platinum being the carboplatin drug, which we use in the first line setting, and we can use for recurrences if we think that the cancer is still sensitive to platinum. And this timeline sort of shows how we define platinum sensitivity. So if the cancer grows either on the platinum chemotherapy or recurs within less than a month, it's considered platinum refractory. If it's less than 6 months, it's resistant. And if it's more than 6 months, it's considered platinum sensitive, either partially or fully platinum sensitive. But in the last few years, the boundaries have been blurred a little bit, whereas before we used to take the 6 months as a fairly hard cutoff. Now, and the guidelines have been updated to reflect this, if there's previously been a good response to carboplatin-based chemotherapy, even if it's less than 6 months, we may consider using it again. But in general, the cutoff is 6 months, and particularly when you think about trials, they usually use 6 months as the cutoff. I'm not going to talk too much about the role of surgery for recurrence, just to say that we do consider it in the first line setting, because I understand that Overcome's hosting a webinar in the new year looking specifically at the role of surgery for recurrent ovarian cancer. But just to say that we do always consider this at the time of first recurrence, and there has been a benefit demonstrated for a second operation, but only in selected cases. So using a second operation, it does improve the length of disease control, and it does improve overall survival. But the criteria are quite strict, and it's based on the results of a big trial from a few years ago called the Desktop study. And this was patients who had recurrent ovarian cancer, and they were randomized to have surgery followed by chemotherapy or chemotherapy alone. And those that underwent surgery and they were able to remove all the disease had a better outcome to chemotherapy on its own. However, there were quite tight criteria, and these are the ones that we consider. So we think about timing. Cancer has to be platinum sensitive, but at least 6, but ideally more than 12 months since finishing chemotherapy for us to consider a second operation. The location of the disease, so all the sites have to be operable, or at least believed to be operable from imaging, and the response to previous treatment. So one of the criteria for the trial was that the original diagnosis, the cancer had to have all been removed at the time of prior surgery. And the reason that the criteria are so strict, that in the context of having an operation and not being able to remove all the cancer, actually the outcomes were no better than not having surgery. In fact, were perhaps slightly worse. So we're confident that there's a role for an operation at the time of first recurrence, but only if we can remove all the disease. And if we do an operation in the first line setting, it'd be followed by chemotherapy, and it would be carboplatin-based chemotherapy. So there are a number of different combinations, which I've listed here: carboplatin and calyx, gemcitabine or paclitaxel, or carboplatin on its own. And if someone's not previously had a PARP inhibitor, so that's niraparib, rucaparib, or olaparib, we can give that in this setting as well. So like I said, that's all I'm going to say about surgery. I'd be happy to take any questions, but there will be another webinar with this in more detail later on, early in the new year. So what about the non-surgical treatment for recurrent disease? Well, as an oncologist, that's what I focus on, and I've split it into 4 sections, talking about treatment for platinum-sensitive recurrence, platinum-resistant recurrence, looking at new drugs on the horizon. In fact, there's hopefully some new drugs that we'll have access to very soon, and then talking about clinical trials and where they sit in the treatment of recurrent disease. So thinking about the non-surgical treatment of recurrent disease, the factors that we consider is the timing. So like I said at the beginning, the timing is probably the most important determinant of the treatment that we would recommend. So whether we define, we think the cancer is platinum sensitive or resistant, the location of the recurrence. So is it causing any complications or symptoms? Or is it likely to lead to symptoms in the short term if we don't intervene? Sometimes, like disease causing lots of ascites or fluid, that might be something we want to treat sooner rather than waiting. Response to previous treatment. So not just was the prior chemotherapy effective, but how was it tolerated? What were the side effects? Is there any lasting side effects? So as many of you be familiar, paclitaxel, one of the drugs we use in the first line setting, can sometimes cause neuropathy, which is nerve damage in the fingers and the toes, and that can be severe and it can persist. So we have to take that into consideration when thinking about next treatment. And other things like blood counts, is there prolonged low blood counts after chemotherapy, may alter what treatment that we recommend. And most importantly, what's important for each patient. Do they want more chemotherapy? What are their symptoms? Is their cancer impacting their life currently? And any other health conditions or comorbidities that we need to consider when thinking about the right option. I think one thing that we talk about quite frequently is something called expectant management, or watch and wait, or observation. There's different terminology. And what this means is when we know the cancer has recurred, but we're not rushing in to start chemotherapy straight away. And the reason for this is that many years ago, there was a really big clinical trial done. In fact, it was run in the UK, where they looked at starting chemotherapy as soon as a CA-125 started to rise versus waiting until patients developed symptoms. And in the long term, there was no difference in outcome. So starting chemotherapy earlier doesn't mean it's going to be more effective. or starting it later doesn't mean it's going to be less effective. It doesn't mean it's going to last for longer, and it doesn't impact long-term survival. So we're quite confident that there's no benefit from starting chemotherapy, particularly in someone who's got no symptoms. And if the disease is low volume, so there's not much cancer on the scan, or it's very slow growing, then close observation is a good option. And why we call it management is because we know the cancer's recurred and we're going to need to do something about it at some point. But if we can maintain a prolonged period of time off chemotherapy and better quality of life, then ultimately that's better for an individual. And what we want to do is use the chemotherapy when we're most likely to get the most benefit, so the biggest bang for a buck, or however you want to say it. But we want to use the chemotherapy when we really need it to maximize the benefit, because chemotherapy comes with, as you'll all be aware, with significant toxicity in terms of side effects and time, the time commitment for coming up for treatment. And this graph, this is from an old publication now, but I think it shows it quite nicely. So if we plot along the bottom time, and up here the volume or the amount of cancer, what we sometimes see is the CA125 start to rise. And often with just a small rise in the cancer marker, the CA125, we might do a scan and there's nothing to see. And we certainly wouldn't start chemotherapy here when the marker's rising, but there's no cancer or only small volume cancer. And then you sort of get this lag where we see an increase in the tumor size on a CT scan, or and people develop more symptoms. And it's about getting the timing right, because here it's too early. And then if someone has lots of symptoms, then we perhaps left it a bit too long. And there's this quite a wide window in the middle where it's all about getting the timing of chemotherapy correct. And because we don't want to subject someone to unnecessary chemotherapy when there isn't a lot of cancer to treat, but also we want to make sure that we get it before someone develops significant symptoms from their cancer. So this is a option that we use frequently. But when we're thinking about drug treatment, platinum sensitive recurrence. So as I said before, this is when it's been at least 6 months following the last dose of the chemotherapy, usually carboplatin, sometimes cisplatin, or if it's less than 6 months, but there was previously a very good response to platinum chemotherapy, carboplatin chemotherapy, then we would consider using it again. And there are a number of different combinations. We all use them in slightly different order. They're pretty much equivalent, but they have different side effect profile. So carboplatin and calyx chemotherapy, it's sometimes called liposomal doxorubicin, that's a combination that's given once every 4 weeks. So in that respect, it's quite nice because it's not too frequent. Carboplatin and gemcitabine, we give for 2 weeks out of 3. So 1 week you have 2 drugs, and then the next week you have 1 drug, and that's every 3 weeks. The carboplatin and paclitaxel is usually given every 3 weeks. We can give the carboplatin on its own. We can think about clinical trials. And then sometimes we use cisplatin in lieu of carboplatin if there's been an allergy to carboplatin. But the order of these, we tend to go carbotaxel first, then this one, carbocalyx second, and carbogem third for platinum sensitive. But it doesn't, like I said, the studies have shown they're pretty equivalent. They just have different side effect profiles. Maintenance treatment, so PARP inhibitors. So when we talk about PARP inhibitors, I mean drugs like rucaparib, niraparib, and olaparib, which many people now receive in the first line setting. So that's after initial diagnosis and first line chemotherapy. We can only use these as maintenance treatment in the recurrent setting if someone's not previously received them. So if they were diagnosed at a time before we had access to these drugs in the first line setting, or if they were earlier stage, so didn't have the PARP inhibitors in the first line setting, or if they had bevacizumab on its own in the first line setting. So it's less and less patients that are eligible for this currently. Bevacizumab in combination with chemotherapy is maintenance treatment in platinum sensitive recurrences, not approved within the NHS. There is a license for it, but actually the benefit of bevacizumab in this setting is minimal. But a question I get asked a lot is, if you've benefited from PARP inhibitors before, why can't you have them again? And actually, there are a number of trials coming through looking at exactly that. So looking at following second-line chemotherapy, is there a role for using a PARP inhibitor again? So niraparib or olaparib. So these are not currently approved. They're not licensed. even in the private sector, or if you have, you want to pay for the drugs, they're not approved. There's no license in America or Europe, but there are trials looking at that. And I think certainly in certain groups of patients, we do think there probably will be a benefit of maintenance therapy in this setting. But we'll watch this space, or consider participating in a trial if that's of interest. In platinum-resistant disease, we tend to use single-agent chemotherapy, so that means one drug on its own. And the options, one we use probably most commonly is weekly paclitaxel, so that's a drug given every week, either 3 weeks out of 4, or sometimes 6 weeks out of 8. Gemcitabine can be given on its own, again, weekly. Calyx can be given once a month. Cyclophosphamide is an oral chemotherapy. Sometimes we use hormone therapies, like a drug like letrozole. Clinical trials, which I'll come on to. Sometimes in the setting of platinum-resistant disease, people opt not for chemotherapy in view of the toxicity, and we focus on managing symptoms and keeping people well. And then it's worth noting again about bevacizumab. So in Scotland only, not in England or Wales or Ireland, bevacizumab is available with weekly paclitaxel in the recurrent setting for platinum-resistant disease, but only if it's not been given in the first-line setting. So that's the only real difference between Scotland and England, but we can't give bev in England in this setting. So for each of these options, the chemotherapy that we have for platinum-sensitive and platinum-resistant disease has been around for some time. So we're always looking to improve options for our patients. And we always think about clinical trials and when available, offer them. And I think, this is quite a nice quote, because it says that clinical trials are the single best way to turn advances of science into patient benefit. And that's ultimately what we want to do, and want to get new options. So just about clinical trials in general. So there's the first part, which is in the lab. So people study new drugs, different cancers, and try and find targets or drugs that they might look effective. And then they move into animal models. And then at that point, they move into humans. And there's a whole process by which a drug goes from the lab into being available, for example, on the NHS. So phase 0, these are trials that tend to be done in healthy volunteers, and they're just looking at giving the drug to a few patients to see how the body metabolizes the drug. So this wouldn't be something that we would normally recommend for a cancer patient, but we do sometimes consider a phase 1 trial. So this is when we have a drug and we're looking at getting the best dose. We're looking at whether to give it, if it's a tablet daily or alternate days, or with infusions, the frequency of infusions. And they're really looking at the safety and the side effect profile, rather than looking for efficacy. Now, historically, for phase 1 trials, they would get any cancer drug, and they would put didn't matter what type of cancer you had, you'd be suitable for the trial, but there wasn't really much thought process into whether you would benefit from the drug. Now, nearly all the phase 1 trials are specific for a particular type of cancer, or ones with a particular genetic abnormality. So actually the likelihood of responding to a phase 1 trial has significantly increased. So there's still safety studies, and there's still drugs that we don't have much experience with, but at least there's some thought process in the drugs that are being used in phase 1 trials and the potential patients that might benefit. So it's they're much more tumor specific than they used to be. And certainly phase 1 trials aren't run in all hospitals, but many of the big cancer centres will have a phase 1 unit. A phase 2 trial is usually a non-randomized trial. So that means everybody gets the drug. And it's when the data from the phase 1 trial suggests that, for example, ovary cancer patients might benefit from this new drug, or a subtype of ovarian cancer, say those with a BRCA mutation or clear cell, or something, a specific cohort, and they maybe treat between 100 and 200 patients on a phase 2 trial, looking at how well the drug works, how many people it works, and how long it works. And these, like I said, are normally non-randomized trials, and these are done in a sort of broader range of cancer clinics because they require less monitoring. I should have said in a phase 1 trial, it's usually less than 50 patients are included. And then finally, phase 3 trials. This is one that can involve hundreds or even thousands of patients. And these are normally randomized trials. So what you're doing in a phase 3 trial is you're looking at the standard treatment and you're comparing it to the new drug, or you're comparing it to the standard treatment plus the new drug. And sometimes these trials involves placebo, but everybody gets treatment on them. So for example, if you were doing a trial, say for platinum-resistant ovarian cancer, you either might get the standard treatment, which would be weekly Taxol, or the new drug, or there might be an option to have the standard treatment plus the new drug, or the standard treatment on its own plus placebo. But everybody will get some form of treatment, but you may not get the new drug. And the phase 3 trials are what are required for a drug to get kind of approval, licensing approval, and then get onto the NHS. So these are the different types of trials that we have, and trials open and close all the time. And what you have today might not be what we have in a few weeks' time, but it's always worth considering clinical trials if that's of interest. And what are the advantages? Well, the main advantage of, or potential advantage of, a clinical trial is that you get access to new treatments earlier before they become approved, and it increases the number of treatment options because you still have the options for the standard chemotherapy, but there's a potential to get a new drug. They tend to have closer monitoring or more individualized care because there's a higher staff to patient ratios, often particularly on early phase trials. So the scans tend to be more frequent. In terms of disadvantages, often there's extra blood tests, biopsies, extra scans like for safety. So we might do brain scans or heart scans or things that you wouldn't normally have as part of your treatment. And nearly always they involve more frequent hospital visits. And sometimes the visits can be long. So we give the treatment and then we may monitor people sometimes overnight or sometimes for several hours. So the time commitment can be, depending on the trial, significant. And particularly for phase 1 trials, these are the ones that are the new drugs, they're more for safety. There's far more uncertainty on the likely benefit and on the side effects, because often they've not been trialed in many people. So we don't know. We can predict them from preclinical models, but sometimes an unexpected side effect can occur. As I said, things have changed dramatically over the last 10 years. So most of the trials that we do now are not on standard chemotherapy drugs. There's very few kind of new standard chemotherapy coming through, but we have far more targeted agents, immunotherapy, cell-based therapies, targeted chemotherapies, so much more varied and exciting range of drugs. We're looking far more at combination studies. Nearly all studies now require biopsy, which can be problematic with ovary cancer because often a recurrence can be within the abdomen and it can be small volume peritoneal disease and it's not easy to get a biopsy, and sometimes they're mandatory to go into a trial. And many of the studies change over time. They're far more adaptive and responsive and often don't require quite as many patients. And we're being smarter about the patients that are included in trials. So we're really trying to maximize the benefit. So, for example, rather than treating everybody with the same drug, personalizing treatment. So if we think a drug works better for someone, there's an example here with a HER2 or say a BRCA or HRD, then we're just selecting these patients rather than giving it to everybody. So as a result, the response rates in trials have improved over the last decade. And when I say response rates, that's the number of people who have a tumor shrinkage. So on the background of trials, we've got all these new drugs on the horizon, and a class of drugs called antibody drug conjugates are really like the hot kids on the block. And at the last European Cancer Conference, nearly all the presentations were on new antibody drug conjugates. So it's quite an exciting time. So there are 2 drugs that have been trialed that are, I guess, more advanced in the phases of trials for ovary cancer: mirvetuximab, which is also called Elahere, and trastuzumab deruxtecan, Enhertu. I don't know why they don't give them easier names. They're always a mouthful. But an antibody drug conjugate is made of 3 main things. You've got this antibody, which is this kind of knobbly, multicolored protein, which binds to something on the cancer cell. So an antibody targets the cancer cell. And then you've got these linker molecules or bridge molecules, which then attach the antibody to these chemotherapy molecules at the end. So the theory is you're delivering the chemotherapy, sometimes at very high doses, directly into the cancer cell. So here, this is this cartoon, you've got the cancer cell, which has got the marker or the antigen on it, this wee triangle, and the antibody binds directly to that and puts the chemotherapy into the cancer cell, whereas it not affecting the normal cells. So here you see it binds to the cancer cell. This is a cancer cell here. It gets taken into the cancer cell, broken up, and then the chemotherapy molecules are within the cancer cell, so they're not floating around in the circulation. So you get direct kill of the cancer, and the concentrations of chemotherapy they can deliver are very high, and there's less. I mean, I'm not there's definitely exposure elsewhere, but far less chemotherapy going to the rest of the body. And with these as these drugs develop, you're getting more and more chemotherapy molecules per antibody, so they're getting more and more concentrated. So the efficacy or the effectiveness is improving. What are the advantages of them? Well, I'll show you some data from ovary cancer suggest that they may work better than standard chemotherapy. In general, they're better tolerated. They certainly have fewer side effects, but the side effects that they can have can be quite different. And the other main difference is that they're usually given for as long as they're tolerating the chemotherapy, as long as they're controlling the cancer. So we give them until progression of disease, and which differs from the standard 6 cycles of chemotherapy. So you don't get this kind of cumulative toxicity that you get with normal chemo. But this side effect can be a bit weird. So mirvetuximab, which I'm going to talk on, can cause conjunctivitis, which is irritation of the eye. Sometimes you can get some unusual lung toxicity, renal toxicity, skin toxicity. So slightly different from chemotherapy. The rates of toxicity are smaller, or are lower, I should say, but they are just something to be aware of, that it can be slightly different. So the one that we're most excited about in ovary cancer is mirvetuximab, also called MIRV, or the brand name's Elahere, which is an antibody drug conjugate which targets something called the folate receptor alpha. So the folate receptor alpha is a protein that's overexpressed on many cancers, but particularly in ovary cancer. So about 80% of ovarian cancers have this receptor on the outside of their cells, which helps the cancer cell grow. And then about a third, 30 to 40% of platinum-resistant ovarian cancers have high expression of the folate receptor alpha. Sorry, I think the fire alarm's going off here. Oh no, stop. Sorry about that. So about I'll go back. So about 30 to 40% of platinum-resistant ovarian cancer have very high expression of the folate receptor. So this is defined as more than 3/4 of the cancer cells having really high expression. And this is what's relevant for this trial, the Mirasol trial, which was a big study performed throughout the world. Many centres in the UK took part in this trial, and it was a randomised trial. So it was a phase 3 trial. So this was the kind of most advanced trial in platinum-resistant ovarian cancer. And people had to have a folate receptor alpha positive cancer. So the original tumours were taken and tested, and if the level was high enough, they were allowed to go on the study. And the study was about 450 patients, and they were randomized, so 1-to-1. So half of the patients received the mirvetuximab, the new drug, and half of the patients received the normal the standard chemo that we would have given without being on a trial. And with all these trials, it's randomized by a computer process, so there's no way of influencing what drugs you get, but it's sort of equaled out across the countries and various things. So it's a randomized trial. Half of the patients got the mirvetuximab, and what they saw was that there was a higher response rate. So more patients treated with mirvetuximab had shrinkage of their cancer. The disease control was longer, and actually the overall survival was about a third longer. So a significant improvement in all the kind of things we look for. And there was a lot of great excitement about this, because this is the first drug in many years that's shown such a big improvement in platinum-resistant ovarian cancer. So this drug, it was approved by the FDA in the US last year, and actually just got approval in Europe by the EMA last week, and it's coming through the MHRA. And I know from the company that make the drug that we're hoping to have it available in the UK at some point next year, hopefully in the first half of the year. So just as a reminder, this is for patients with platinum-resistant ovarian cancer that's folate receptor alpha positive with high expression. The second drug, which is not quite as far on, we only have a phase 2 trial, is this TDX, which is looking at HER2. So HER2 expression is very common in breast cancer and endometrial cancer. In ovary cancer, it's far less common. It's only about 10%, and it's probably slightly higher in some of the rarer subtypes, so endometrioid, mucinous, and even clear cell, and to some extent in serous, but not as many. And they did a trial where they took any cancer type with HER2 overexpression, and the response rates in ovary cancer were very encouraging. So here, this is looking at the percentage change of the tumor size from starting. shrinking. And anything that goes up means the tumor grew. Anything that goes down means it shrunk, with this being 100% shrinkage, and then the various numbers here. And if we look at the ovary cancer cohort, that's the one in green here, the majority of the patients had some degree of tumor shrinkage. And in fact, more than half of them, I think it's about 50–60%, had more than 30%, which is kind of what we consider a reasonable response. So this drug isn't currently available. It actually has approval in the US for any HER2 positive cancer. It's going through the European approval, but there are a lot of trials ongoing using this drug and other drugs that target the same thing. So again, not relevant for everyone, but in the patients that do have this marker, these drugs seem to be particularly effective. There are loads of antibody drug conjugates on the horizon. So these are all the different targets. You don't need to worry about the names, but these are what all these drugs are in development, with the rates of overexpression in ovary cancer along the bottom. So some of them, 50% plus. And there are trials going on with all these targets. So hopefully, if I was to do this talk in another year or 2 years' time, we'll have way more positive trials. Certainly the initial studies, so the phase 1 trials or the phase 1/2, where they've treated a small number of patients, the response rates for cancers that have the biomarker seem to be very promising. And these are trials that we're running in the UK, either they're open or on the horizon for the next few months. So there are some looking at these drugs in platinum-sensitive recurrence, either with carboplatin or instead of carboplatin, or in the case of mirvetuximab as maintenance treatment. And then there's a whole host in platinum-resistant recurrence. And actually, there's another trial with folate receptor alpha that's the same as the mirvetuximab one, which is using a lower cutoff, which is just about to open. So it's a very similar drug. And we're looking at these drugs as maintenance therapy in the recurrent setting. And there's a study going on for first-line maintenance for HRD negative cancers or HER2 positive cancers. So this is really where all the focuses or all the kind of phase 2 to 3 trials are with ovary cancer. So it's an exciting time to be involved with these. Antibody drug conjugates are not the only things under investigation in recurrent ovarian cancer. So there's, in addition to the ones I've talked about, there's sort of immune stimulating antibody drug conjugates. There's bispecific antibody drug conjugates. That's when they target two things, maybe on the cancer cell and the immune cells. Immunotherapy in general in ovary cancer hasn't been very successful to date, but there are a number of different new immune targets and looking at combinations, CAR T therapy, vaccines, viruses, etc. All these novel immune modulators whereby you can take out someone's immune cells. You take it like donating blood, but we extract the immune cells and then modify them to attack the cancer and then reinfuse them back in. Those studies are ongoing. And then we mustn't forget sort of all the drugs that have been so beneficial to date. So PARP inhibitors, so that's drugs, olaparib and niraparib, etc. Looking at them in combination, looking at giving them again as second-line maintenance. Other drugs which inhibit DNA like PARP inhibitors, targeted therapy, looking at other pathways that are activated in cancer, and the list goes on and on and on. So it's really an exciting time to be involved in research. And actually, like I said earlier, we're not just looking at chemotherapy. In fact, we've almost moved away from chemotherapy. We're looking at all these different types of treatment. Just going to finish with talking about a couple of other considerations for recurrent ovarian cancer, away from kind of systemic treatment for the more common high-grade serous type, so low-grade cancer, and then looking at single sites of recurrence for people who are on maintenance PARP inhibitors. So low-grade serous ovarian cancer is far less common. It represents about 5 to 10%, and in general, chemotherapy is less effective. We often use, excuse me, hormonal therapy, so drugs like letrozole or tamoxifen. But there's one of the pathways in low-grade ovarian cancer. This is called the MAP kinase pathway. So here there's growth factors on the surface of the cancer cell, and then they stimulate the cell to grow. So this specific pathway is very upregulated. That means overactive or almost out of control in low-grade cancer. And there are drugs that can block this pathway. So the LOGS trial, it was another international trial done and we did it in the UK. And this was for people with recurrent low-grade ovary cancer, and they either got this drug trametinib or our standard of care choice. So we could either give chemotherapy or hormone therapies until for as long as the drug was working. And they demonstrated that trametinib was far superior to the standard treatment. So and controlled the cancer for at least 6 months longer. And so trametinib is now an option for recurrent low-grade ovarian cancer. So only for low-grade, it doesn't work in any other subtypes, but it's a reasonable option. And there's now studies underway looking at drugs like trametinib, but in combination with something else to see if we can improve this further. So that's for low grade. And then the last thing I just wanted to touch on was what we call oligometastatic recurrence. So the definition of oligometastatic means a limited number of sites of recurrence. It's actually not a defined definition, but it usually means in this setting up to 3 areas where the cancers come back. And we sometimes consider whether these may be suitable for radiotherapy. So stereotactic radiotherapy is very high dose radiotherapy, but it's very targeted. So there are many areas where radiotherapy is not suitable. So on the bowel, liver, the main organs. But for example, a lymph node or isolated peritoneal nodule that's far away from the bowel, or a lung metastasis sometimes may be suitable for radiotherapy. So occasionally, and we're doing it more often, it's not yet standard, if someone is, for example, on olaparib or niraparib, and one site of recurrence pops up and it can't be removed by surgery for whatever reason, we may consider some stereotactic radiotherapy, and then we have the option to continue with the maintenance treatment afterwards. And this is something that's been looked at in a trial just now, the Soprano trial, which is looking at exactly that. So if you're on a PARP inhibitor and you have a recurrence, but it's isolated number of sites to go for radiotherapy and then continue with the niraparib. So radiotherapy may take on a bigger role for recurrent ovarian cancer in the future. As I said, now it's fairly limited, but occasionally it can be very good at getting control for a small area of the cancer. I think that takes me to the end. So it's worth stating that recurrent ovarian cancer really is a chronic condition, and it can involve multiple lines of treatment over many years with many periods off treatment. And what we want to do is maximize the time off treatment and give the best benefit from any treatment that we give. So we want to utilize treatment for maximal benefit. And really, there are so many new treatments under development. So for the last decade, we've been looking at improving things in the first line setting, but now there's really a big focus on particularly platinum resistant, but not just that, but recurrent ovarian cancer, and looking for new drugs with less toxicity. And I certainly expect that if I was to give this talk in 12 months' time, that there'll be many, or hopefully many more approved therapies or positive trials to talk about. So I thank you all for the time. I include here my teams at Barts and then UCLH, and then here's some of the Overcome team. And you'll notice that no one ever carries the ovary. I always have to be the one running in the costume, but I'm always happy to help with Overcome, and I'm pleased to take any questions. I'm just going to stop sharing my screen. Thank you.
Thank you, Rowan. And I'm glad that you treated everybody to the picture of you in the ovary, and it meant that we didn't have to share it.
But you'll notice that Victoria wasn't wearing the ovary.
No, you would not catch me in the ovary. That will not happen. That was so Rowan's so much fitter than any of the rest of us. So Rowan, I do have a few questions for you. Those of you that are popping questions in the Q&A box at the bottom of the screen, we're going to go in order of questions and give Rowan time to answer them. So we have, Rowan, a question here from anonymous attendee. Is age a factor when surgery is being considered?
No. So general fitness, so we never really use age as a factor. It's never a defined cutoff. General fitness might be. So, but that's not age dependent. So it would depend on other comorbidities. So as anyone having an anesthetic, age slightly increases your risk, but in someone who's otherwise healthy, it shouldn't make it impact anything.
That's wonderful. Thank you very much.
And we have, just to say, I put people in their 90s on clinical trials, so age is not a factor.
Which is fab. What is the science and practice with regards to taking metformin after chemo treatment of a recurrence?
Well, so I'm not an expert on metformin as an anti-cancer therapy. That's my first disclosure. There is some evidence from the lab that metformin can kill cancer cells, or can make it a less permissive environment for cancer cells to grow. I don't think there's been any good quality clinical trials showing that metformin is beneficial in reducing the risk of cancer recurrence. That doesn't mean it's not effective. It just means that there's not good data to support it. So I don't think metformin is a very nice drug, and it can often have quite nasty side effects if you're not diabetic. But certainly when you're not on chemotherapy, there's probably no harm in taking it. I'm just not sure of the data that supports it.
That's fantastic. Thank you, Rowan. Just worth noting, I have dropped the support service contact details for participants into the chat box. Support team is always available to answer your questions on a one-to-one basis and to give you personalised information. And just to give you reassurance as well, if you come to us with any questions that we find we can't answer because it's not current information that's currently available to us, we would ask one of our expert advisory panel members, and that is likely to be Rowan. So if you don't, Rowan, or if it relates to surgery, one of our surgeons. So if we don't get to your question today and you do have additional questions, or if an answer sort of or the presentation has thrown up any other questions, please do get in touch with our support team. Liz, if you could drop the number back in a minute, that would be fantastically helpful. I've got another question here, Rowan. Are the NHS rules about what drugs are or are not allowable for treatments applicable if the patient is under private care?
So as it stands currently today, so there's okay. The first thing is even in private sector, we can only prescribe drugs that are licensed. So you can't go rogue. With certainly private insurance companies don't cover it, and if our private MDTs wouldn't approve treatment. So the only drug until last week, mirvetuximab was approved in the European Union, was bevacizumab for recurrent disease. That's the only drug that you can get in the private sector with insurance or pay for that you can't get on the NHS.
Fantastic. Thank you very much.
And I should say that there is in some trusts an option to have top up with bevacizumab. It's now off patent. It used to be very expensive. It's still expensive, and not all trusts do it, but occasionally it's available to top up with your chemo.
Thanks. And again, that's a question that if any of you have relating to you personally, it's worth flagging to our support team because they may have further information or they may be able to help specifically with individual circumstances. So next question, why is Elahere mirvetuximab only relevant to platinum resistant?
So the reason is because that's where all the trials have been done so far. So it's only been shown to be efficacious in effective in platinum resistant disease. It may well be effective in platinum sensitive disease. So there's a trial ongoing now called the Gloriosa trial, which is looking in platinum sensitive recurrence, and you have the platinum based chemotherapy, and then they give it as maintenance treatment. I'm not sure about giving these drugs as maintenance treatment because they still have toxicity, even though it's not as bad as chemo. And there are trials coming through for platinum sensitive disease comparing mirvetuximab with platinum based chemotherapy. But the reason it's not available is because there's no evidence to support it. But there may be in the future.
Thanks, Rowan. A BRCA question. Are there any BRCA 1 or 2 specific trials or upcoming drugs?
So there are a couple of trials looking at PARP inhibitor, either combinations, or there's a new PARP inhibitor that might be a bit more potent for people who are BRCA or HRD coming through. So there are some studies. For every trial, I should have said, they all have quite strict inclusion criteria and exclusion criteria. So they may only be appropriate if you've got platinum sensitive or platinum resistant, or if you've had less than 3 lines of treatment. So they all have different criteria. But yes, in answer to your question, there are some PARP specific BRCA trials coming through.
Thanks very much, Rowan. A couple of questions coming through about sharing the slides, but also just to make everybody aware, we are recording this. And so this is going to be shared on our YouTube channel. Again, if you have any if you struggle to find it, or you want us to send us the link specifically over to you, then you can always give us a call and we can send you the link either on your phone, or we can send it when it's up on a YouTube channel to your email address. So, and the slides will be included within them, obviously, because it's a recorded webinar. So I have a question here. There is a trial called Fontana. Could you please explain this trial? Many thanks.
Yeah, I just saw that question. I don't know that trial off the top of my head, sorry.
Okay.
So I can't. I think it's a mirvetuximab trial. But there's so many trials and they've all got weird and they've all got different names. So I'm sorry. If it's something your oncologist has recommended, or you may be able to find more about it on clinical trials, but I don't know the answer to that one, I'm afraid.
Question here. If you don't live near a cancer centre, which I think is major cancer centre, like a trial centre, are you less likely to get the more interesting treatments?
Well, when drugs come through, they come through everywhere. So if a drug gets licensed on the NHS, be that something like mirvetuximab, it's available at all places at once. It gets NICE approved, and there may be some slight variation when the hospital implements it, but it shouldn't. But in terms of access to clinical trials, it is hard if you don't live near a cancer centre where they run them. So the UK Gynae group is making a concerted effort to spread the trials more equally around the country, because they're very conscious of that. And obviously, if you live in London, there's 4 or 5 big cancer centres, so there's lots of options in a short. So it's very unfair. So there is a concerted effort to spread the trials out, particularly all these ones for platinum-resistant disease, because there's so many trials, and so we are trying to spread it out around the country, but it definitely can be an issue. The second thing to say is for many of these trials, because they're sponsored by the drug company or the pharma company that own the compound, there is some money towards traveling, and overnight accommodation and things. It may not cover everything, but it's sometimes fine. Money shouldn't be a reason not to take part in the trial, but I understand that traveling can be a big commitment in terms of time.
We have a question in here, Rowan, which I'm just going to do a very brief response to, but also you might want to add something. To what degree is cost a factor when deciding on a treatment, e.g. PARP? And I think that refers to NICE and SMC, so the National Institute for Clinical Excellence and SMC, perhaps.
So for us, once a drug's approved, we don't think about the cost. So, it doesn't, we would offer whatever drug's the best. The NICE and SMC, they do a cost effective analysis to work out the benefit versus the cost of the drug. But as I said, with the exception of bevacizumab for recurrent disease, we've got access to all the drugs that have been approved, and I'm sure mirvetuximab will get approved. So actually for ovary cancer, because the drugs that have come in have shown a significant benefit, they've all been approved. But yes, you're right, the cost is taken into consideration. But the other thing is NICE and the SMC have quite a lot of bargaining power for the pharma companies, because they know that there's a set amount that they'll not pay over. But I don't get involved. Fortunately, I don't have to get involved with that. Sometimes we give our expert advice, but we don't have to comment on the cost.
And just as either reassurance or as a point of reference, so Overcome sits as a patient advisory group on, and we make submissions to represent patient voice on the panels and at the meetings with NICE and at SMC meetings. And so it really is one of those systems where if we can make a really strong case, actually, sometimes that is listened to by NICE and SMC. And so I think there is a balance. Yes, it is, cost is a factor, but also, and also all of the data from the trials and so on is the biggest factor. But I think patient voice is having an increasing impact as well in making those decisions. So we've got a question here. Which OC subtypes are most likely to respond to mirvetuximab?
Well, that's a very good question. So on the trial, the criteria was folate receptor alpha positive. So it was based on the biomarker, not the subtype. The majority of patients were high-grade serous and high-grade endometrioid, and the expression, say, in clear cell is very low. But because you're targeting the biomarker, if the biomarker is present, then you should have the same chance of responding. But because it's more common in high-grade serous, that's the one. The other one, the TDX, the HER2 one, actually the rates are far higher in the non-high-grade serous subtype.
So there are a few questions in here about surgery. And what we are going to do is our support team can probably, so Rowan is an amazing medical oncologist, and we are not going to make her answer questions today about surgery, or put her colleagues on the spot.
I can say about surgery that nearly everyone who has a first recurrence, we would consider for surgery. And as I said, the criteria are fairly strict. And we consider every case, and there's a project going on looking at all the patients that get considered for secondary surgery. As to the other questions on surgery, I can't answer.
We will have a talk next year. We confirmed it with Christina Fotopoulou from Imperial. And if you want to find out more about that, you can always get in touch with the Overcome support team, and they can pop you on the list and let you know dates and so on when we have that all confirmed. I've got a question here, Rowan. What is the significance of the HRD positive or negative category in recurrent cancer?
That's a really good question. I mean, it's like I said, the main thing for decision making is the timing. So, whether we define something as platinum sensitive or resistant. So once beyond the first line setting, HRD status is less significant because HRD status can change with time, and we're kind of more interested in how the cancer's behaved since its last treatment. The only way where it might make a difference is when I mentioned that trial with BRCA included HRD positive. So it may make a difference in terms of what trials are eligible, but in general, it doesn't influence what treatments we would offer in the recurrent setting.
Thanks, Rowan. Next question. You're rattling through these, and thank you very much indeed. So the next question, are there any trials available for clear cell ovarian cancer?
Yeah, and I saw there was a question about mesonephric as well, so I could probably
Yes,
answer them both together.
thank you.
So there aren't any specific trials for the rare subtypes. We had a really good trial called the Bouquet study, which took all non-high grade serous rare subtypes and profiled them and matched treatments, but that's closed, unfortunately. Some of the trials, particularly some with the antibody drug conjugates, are not histology specific. So like I said, if you've got the biomarker, you can test your tumor, and if you've got the biomarker, then you're eligible for the trial. So some of the trials coming through with the antibody drug conjugates, not mirvetuximab, but the other ones are for any histology. And some of the earlier phase trials are allow all sorts. And yeah, but specific trials for clear cell, I think there might be one on the horizon called the Dove trial, but I haven't heard much about that recently. But like I said, many of the new trials don't exclude other histology, or include, I should say, not they don't exclude, they include all histology.
Thank you, Rowan. We've got someone here who is interested in trials of PARP inhibitors following first recurrence, i.e. taking it for a second time. So you briefly
Yeah,
know.
so there's a study coming through called, again, the name escapes me, and it's on hold just now. I'm not sure what's happened with the new AstraZeneca PARP inhibitor, which is thought to be more potent, looking at exactly that. So re-challenge with or second line of PARP maintenance. As I said, it's on the horizon. I don't know what the timelines are. And as I mentioned to the other question, there are studies looking at PARP inhibitor combinations, more as treatment than as maintenance for BRCA and HRD cancers.
Thank you. We have a couple of questions in here about diet, and what I would do with those, unless Ryan, you particularly want to answer them, is I would say that we do have a wealth of resources at Overcome, some specific myth busting webinars, and also some further information from dietitians that might be helpful. So let's see what else we've got here. We've got, okay, so maybe another question or possibly two, Rowan. Is that okay?
Yeah, that's fine. I was just looking at the questions as well.
Yeah. Are there any that you particularly want to pick out that?
Well, one of the first ones was about the duration of PARP inhibitors in the first line setting, and that's I think is relevant because we get asked that quite a lot. So why do you only give it for 2 years for olaparib or 3 years of niraparib when the risk of recurrence is high? And I mean, the reason that they were chosen on the first instance for the trials is because the greatest risk of recurrence is in the first sort of 12 to 18 months, so that period covers it. And for those on those studies that we did, we didn't see a big jump in recurrences when the treatment was stopped. And the reason that we don't give these drugs indefinitely in the first line setting is because they're not without toxicity. And there's the potential risk with increased use of things like blood disorders and leukemia. So that's a question that I get asked really a lot, of the risk of recurrence. Why don't we give PARP for longer? But actually, the data doesn't pan out. So the longest data we have is from the BRCA olaparib studies where they got olaparib for 2 years. And actually, there wasn't a big rise in recurrences when the treatment was stopped. And actually, the majority of people who are okay at 2 years remain okay at 7 years, so, which is the longest follow-up we've got.
Thanks, Rowan. We've got a question here. If a patient is platinum resistant, does that mean that paclitaxel could be used again? I know we
Yes.
had that. Yeah, we had that question as well offline, so emailed into us. So
Yeah, and sometimes if someone's platinum resistant, we give them a non-platinum trial, and then there's a period of time when we try platinum again. So there's no fixed recipe and not really any order. And if someone has had a really good response to paclitaxel for platinum-resistant disease, and then it's a year later and they've got no neuropathy. We sometimes we can use the same drugs again. It really depends on what I said about response to previous treatment in terms of how well it worked and what the toxicity was like and how well it was tolerated. So there's not like a roadmap of a certain order of treatments. It depends on various factors. And every time we think about treatment, we think about the different, we consider all the different options.
That's wonderful. Thank you very much. We've got a few thank yous coming up in here, and that just mirrors our massive thank you. And we've got a question in here. What's the best way to keep up to date with new trials coming through? I would always have, we have this question a lot at our face-to-face events. And there are some trial databases that you can look at, and they are good, but they're not going to tell you whether or not that trial's full or whether or not that trial is, whether or not you might meet the criteria for your trial, for that particular trial. Generally, at certain points, we do tend to hear from people, and the support team will give individual responses and will help people understand what the date, what is out there, what is accessible, what's not accessible. But also I think it's really important to think about, if you want to go on a trial, why do you want to go on a trial, and what's the impact perhaps going to be on your life as well. It can be difficult and exhausting, and it can be fantastic if you end up on a trial that is helpful to you. Was there anything that you wanted to add in that, Rowan?
No, I guess it's all for trials. Like you said, you guys are very useful, and the databases are often out of date because things change so quickly. The gynae-oncology for community tend to be quite well averse, and certainly many oncologists who don't do a lot of trials are always referring patients in or asking me if we have anything. So I think if you're interested, it's always worth speaking with your oncologist, and then if they don't have any, if you've not got anything at your hospital, whether they can suggest something somewhere else.
Right. Well, so we have 1 minute to go, and thank you so much, Rowan, for answering so many. That was like a whistle-stop tour through so much information. Again, we have dropped our number in. If anybody does have any follow-up questions, we'll be happy to, the support team will be happy to receive them. And just a massive, massive thank you to you, Rowan, for all of your help,
You're welcome.
and
Thanks for having me.
for consistently giving us your time, and for explaining such complicated things in a way that's understandable even to people like me. So thank you very much indeed for your time. We are very, very grateful. And thanks to everybody who joined the webinar. It will be available. We will let you know when it's up on our YouTube channel. Thank you very much.